1.
The broadcast is now starting. All attendees are in listen-only mode.
You're on the ear, Joe.
Got it. Good afternoon, everybody. Welcome to the Neuroscience of Addiction Part 3 on relapse. This is the third part in a three-part series that we run all September. My name is Joe Lunievicz. I'm the Director of the Training Institute here at National Development Research Institutes. A special nod of appreciation over to Clyde Fredericks, our webinar organizer and administrative technologist, who's keeping the webinar running smoothly from a technological perspective. Today, I'm going to be talking to you about what we know through neuroscience, which has been the theme of all three of these webinars, how science informs our practice, right? But specifically this time of the phenomenon of relapse in terms of brain disease, the brain disease that we call chemical dependency. So as a reminder, this webinar is brought to you by the Bureau of Justice Assistance, BJA, Drug Courts Technical Assistance Project at American University, Washington, D.C., in collaboration with us here at NDRI, otherwise known as National Development Research Institutes. So let's go over some logistics of our webinar. Let's take a look at, for those of you who've heard this before, just bear with me. For those of you who are new, check out these three areas: your panel, your question box, and the ability to raise your hands. So the first piece of this is the control panel, orange arrow. Click it once or twice so you can open and close the panel anytime you want. If you want to see the full screen, you close the panel. If you want to use the control panel, you open it up. As you can see, you can close it down or make it bigger. The ability to ask questions and or to answer my questions, to text them in. So if I ask you to text in an answer to a question, here's where you're going to go. You'll open up your control panel. You'll just type in your response into the question box, and then you'll come right here to where it says send. You'll click this button, and the text will come right into me here on my second screen, so I can see your questions as they come in or your answers as they come in. So that's the question box. The ability to raise your hand electronically is a fascinating little thing we've got here. You can see the little hand icon with the green arrow. If I ask you to raise your hand for a reason, then you click on that button and your hand will raise on my side, and I'll be able to see how many people agree or disagree or think that's important, or for whatever reason I've asked you to raise your hand. So actually, let's do that right now. Everybody who's online, just so that I know you're listening and that you can understand what I'm saying, let's take a look. Everybody raise your hand. Click on that little marker. So I see hands going up all over the country. Wonderful. And I have the ability to take everybody's hands down, so I will do that. Looks good. So that's our electronic hand raising. Technical difficulties: if for whatever reason you have any trouble listening, hearing, or with any of your visual problems with your screen, call 800-263-6317, and that'll get you to the Citrix folks who are our GoToWebinar hosts. They take care of the hardware side and software side of things. So if you have problems, that number will be repeated on each of the slides, especially in the beginning. Just call them and they'll get you back up online and back with us here at the webinar. Okay. So again, my name is Joe Lunievicz. I'm the Director of the Training Institute. I've been the presenter for the last two of this whole series. I've got about 20 years of experience working in drug treatment as a provider, more specifically as a training provider in the second half of that time, and in the last decade plus as a drug court staff developer. And I have a lot of different areas I have expertise in, including drug treatment, relapse prevention, which is what we're going to talk a bit about today, and a lot of the science that goes on behind chemical dependency and drug treatment work that we do. So what are we going to talk about today? Here in Part 3, we're going to talk about what is relapse. We'll look at it within the context of the disease model of addiction, which means we'll look at it from a biopsychosocial perspective. We're going to take a look at the neuroscience that we've learned so far in the first two pieces and see what about the neuroscience and the damage that's done to the brain through the process of addiction, how it impacts or how it will present itself through this phenomenon of relapse. So not only will we look at what is relapse, we'll look at how relapse is within the context of chemical dependency. And then we'll look at we'll place relapse in the context of what's called, and what we talked about last week as post-acute withdrawal symptomology. And we'll take a look at the implications of relapse prevention to drug court practice, specifically in the areas of sanctions and incentives. So you tell me, let's start off with you getting a little bit of exercise with your fingers in your text box. When a participant relapses, I feel, give me a one-word answer. No novels, no long paragraphs. One word, short and sweet. When a participant relapses, I feel, please complete that statement. Text in your answer to me. Let me see what you guys come up with. On this Thursday afternoon, depending upon where you are, late or early. Keep them coming. I've got a few so far. I'll start reading them off in a moment. When a participant relapses, I feel, I know this is dangerous, asking a feelings question, but nevertheless, let's give it a try, folks. Work with me on this. Okay, so here's some of the answers that are coming up. I've got sad, concerned, hopeful, empathy, empathy again. I feel like giving up. I feel disappointed. I feel angry. I feel disappointed. I feel hopeful and mad. There's a great contrast in feelings on both ends of the spectrum, right? Any more coming in? Okay. So I've actually I've asked this question in workshops across the country to 300 plus drug court practitioners, and the top 5 answers are disappointed, sad, frustrated, mad or angry, and concerned. So think about the answers that you gave, which are right on target with the answers I've gotten nationally. What does this tell us about drug court practitioners' response to relapse? Text in your answer to me. What do you think this tells us about you as practitioners with regards to relapse? Someone give me an answer. Think about that and then text in your response. What do you think this tells us about how drug court practitioners respond to relapse? Here's one answer. Drug court practitioners are invested in offenders' successes. Certainly, yes. We feel very much a part of the process. We've got time, effort, and to some degree some emotion invested. I have someone else who says we're wanting the best for our participants. Yep. Someone else says we put our hearts into the work and are disappointed when things don't go right. Yeah, this is a fascinating statement. We put our hearts into our work. The second part is what's even more fascinating in some ways. We're disappointed when things don't go right. So this is something I'm going to hope to challenge this afternoon with all of you. The concept of things going right versus things going wrong when it comes to relapse occurring. Someone else wrote taking responsibility for client behavior. Someone else wrote that they are personally invested in failure or success of participants. And this is another area which I think is just fascinates me in my work on relapse with folks. And it's very much makes sense because of our training that we tend to look at relapse as failure and that no relapse means success, which is problematic in a way, and we'll talk about why. This is one of my favorite questions to ask practitioners. What do you do when a participant relapses? So if you feel this way, these are the ways that we feel, what kinds of actions do people take? And this is my favorite answer. We do a case autopsy to see where the program has failed the client. Now, I don't know about you, but right away I'm looking at the word autopsy. Having problems just getting past there all by itself. And then I'm taking a look at failed the client, right? So this concept of success and failure, and at a very strong level, right? At a very strong level. So it's not just a little bit, it's a lot. The depth of the feelings. I've had people tell me, you know what this means to me? This means that I have feelings about my clients, and I had no idea that that was possible. I know that may sound silly to some, that may sound very surprising to others, but the truth of the matter is that we have as drug court practitioners. We tend to have strong emotional responses when our participants relapse. And it's because, as many of you have said, put our hearts into our work, we take responsibility for client behavior, we're personally invested in the time and effort and in these individuals' lives because we find out about their stories and we care. And sometimes we want to care, sometimes we don't want to care, but we get involved in this idea of getting involved in a different way than perhaps in a traditional court setting because of the access to the kinds of information we get about our clients leads to emotional response. And of course, as we know, when emotions come in, behaviors may occur. And one of the things we have to be careful with is how we behave when we feel this way, right? So our response to relapse is going to be crucial in our ability to work effectively with clients around relapse. So it brings up these kinds of questions. Is relapse a failure? How can relapse be seen as a success? Can we see relapse as a success? And I like to think that relapse can be very much seen as part of the recovery process, as part of the treatment process, mostly because relapse tends to be so common. And I'll go into some statistics later on in the webinar. But if we can change the way we look at relapse, we may be able to see it in the context of chemical dependency. And if we can see it in the context of true brain disease and chemical dependency, then we can be more effective in meeting the needs of our participants and our court and treatment programs. So all three of these things can come more into line. So how do you see relapse as a success? Well, think about it just for a moment. You know, what happens when someone relapses? Well, it means they had to have been clean and sober for a certain period of time. It means that they have been engaged in treatment. And it could be 1 hour, it could be half an hour, it could be 1 week, 1 month, 1 year, but they've been involved in being sober for a certain period of time. And that, I think, is one of the parts that we tend to forget. Relapse means that engagement in the treatment process has occurred. That's a very positive thing. You can't relapse unless you've been clean and sober for a period of time, regardless of how long that is. And remember, we may be talking about folks, if you're chemically dependent, you have a history of substance, not just substance abuse, but a history of dependent use over time. All right, so a period of being clean and sober, of even a short amount of time, is really something to notice, as opposed to the relapse. Not that it's not noticeable, but putting relapse in context is going to be very helpful for us. So what is an appropriate expectation around relapse? That's one of the things we're going to talk about today. We want to see relapse in the context of a brain disease, remembering that the influencing factors for severity are biopsychosocial and include things like the drug itself, its addictive properties, how long it's been used, how much, the genetics of the individual and their family history around substance use and around dependency, and of course the environment that they're living in. All these things, as we've talked about in the previous two webinars, are going to influence severity. So Marlowe and Gorski, who are two of my favorite researchers, and they're kind of like the grandparents of the relapse prevention movement. Their work is still very applicable today, and this relapse movement is strewn with their material in the evidence-based practices, right? They would say that there are 3 types of clients: those who are prone to recovery, those who are prone to relapse, and those who are chronically prone to relapse. So if you take a moment and look at mitigating factors, such as the drug itself, such as genetics and family history, genetic vulnerability to dependency, right, and the environment that they're living in. You know, someone who's prone to recovery might be someone for whom they're using a drug from our first day that we'd worked together, which has less addictive properties, whose genetic vulnerability is low, right, because there's no family history or limited family history, and the environment might be a very anti-drug use environment, so it would be supportive. Someone who's prone to relapse might be someone who's using a drug, for example, that might have higher addictive qualities. Just as an example, say crack or cocaine, who has genetic history. In other words, the vulnerability is high because family history of dependence is high, and the environment might be pro-drug use as opposed to anti-drug use. or maybe just a little bit of this if they're prone to relapse. Chronically prone to relapse, all those factors, you'd have check marks on all three. So in a very simple way, you can see how you can take these concepts and expand them to the American Society of Addiction Medicine's ASAM criteria, where they look at these domains of which these are all concerned, all part of the domains we talked about last week, for assessing where someone should be put, what level of intensity of treatment they might need. It also gives us clues to the probability of recovery and the probability of relapse occurring during recovery, right? How much or how many times. So again, neuroscience supports the concept that addiction is a brain disease, and the reasons for starting drug use, for continued drug use over time, which we've just gone over, drugs, genetics, and the environment. And the treatment approaches addressing each can be seen from a bio, psycho, social, and spiritual perspective. So let's all say this together. Addiction is a brain disease. One more time, with a little bit of feeling. Addiction is a brain disease. And this time, just because I want to see if you're really out there, I want you to say it by yourself. I won't say a word. That's what I like to hear. Excellent. So reasons for starting drug use, we know may very well be different for continued use over time. When dependency occurs, continued use over time is because the brain has neurochemical changes to the brain have occurred, specifically damaging the reward pathway, interfering with dopamine synthesis and modulation of the prefrontal cortex. I know that's a mouthful, but if you guys have been with me for the last 2 weeks, you know exactly what I'm talking about. Right? Prefrontal cortex, the front part of the brain, which is mainly responsible for decision-making, focus, concentration, the ability to say things like, you know, on second thought, maybe I better not do that. Right? That ability, that capability is what's impacted by the disease of addiction. Right? And of course, what treatment does is tries to repair that damage over time. And what we know about chemical dependency as a disease model, besides it being a disease of the brain, is that we know that there is evidence that the brain does recover in treatment. The caveat to that is, of course, some drugs, like, for example, heavy alcohol use or, for example, methamphetamine also, result in actually permanent damage to the central nervous system, to the brain, to these pathways, the reward pathway to the prefrontal cortex, right, the front of the brain. What's good news is that although that damage may not be fully repairable, the pathway to that part of the brain, that exact pathway, may not be able to be used again. The brain has a wonderful capability of finding new pathways to those same places. What that means is it will feel different for someone to problem solve, and they may do it in a different way or in a different capacity. But they may still, with treatment over time, be able to find those capabilities again. Of course, that means it just may be harder to do. So however much can be restored, and the brain can develop, so we would call compensations for these damaged areas. Different routes. Some of the routes may be longer, not as efficient, but they'll still get us to the same place, hopefully. That's the idea. Remember that the chemical dependency is a chronic condition requiring lifelong management, and that no one treatment episodes will resolve illness. So it's not treat once and you're all set for the rest of your life. It usually requires multiple episodes of treatment, different kinds of recovery activities, periods of relapse, whether they be single lapses, medium-term or longer-term relapses, and hopefully returning to recovery and stabilized periods of recovery. So let's take a look at our definition of recovery from Terence Gorski again. He says, ongoing process of improving one's level of functioning biologically, psychologically, socially, spiritually. So notice the connections here in the way we're looking at brain disease and the way we're framing not just treatment but the whole recovery process. Right? Of course, while maintaining abstinence. Right? Remember that during acute withdrawal, which is basically the time period when the drug is getting out of the system, we have predominantly biological symptoms that we're working with. So acute withdrawal is right here, dealing with specifically more physical symptoms, whereas post-acute withdrawal works more with the emotional psychological. And acute withdrawal, as we'll go over in a little while, is again our first week or so, maybe up to first month, while post-acute withdrawal can last as long as 6 months to several years, depending upon the factors of addiction that are influencing it. All of this, again, of course, while maintaining abstinence. So then let's look at a definition of relapse. Our friends Marlowe and Gorski one more time. And what do they call it? They call it an unfolding process in which the resumption of substance use is the last event in a long series of maladaptive responses to internal or external stressors or stimuli. And let's remember, internal or external, right, that whatever we take in, either internally, right, biochemically, or externally, what we feel, smell, experience in a central way, has to be processed by our brain, and then through our neurochemistry create reactions to, right? So let's look at some of the important words in this definition. Unfolding process. So it's not like you wake up and go, oh, relapse, there we go, boom, it's all over. It's a process that begins many times before the substance user has, or the person who's addicted has any sense that it's beginning. So knowledge of when the process begins then is going to be very important for all of our participants as far as information that will be useful to them. Because if you know when the process is starting, you can stop it at an earlier place. The closer you get to the relapse, the harder it gets to stop, right? So unfolding process. Use is the last event, so that's what we tend to see, right? It's the last event in the process. A long series of maladaptive responses. So maladaptive responses, the substance use is a maladaptive response. Whatever need that was the original need for using, okay, the drug probably did its job. You wanted to feel better, you felt better. You wanted not to feel some of the negative impacts of some trauma that occurred, so that happened. Problem is, over time, it's not doing the same thing, and it's not needed for the same thing. And so what was adaptive at first, it becomes maladaptive during abuse or dependency because of the negative implications, right? And then, of course, you've got internal or external stressors, which are exactly what we've talked about. There is, and this is from NIDA, and Marlowe and Gorski's work, which has been published there. There's also one other piece of relapse, abstinence violation effect, and I'd just like to bring this up just as one of those pieces, because many times people, drug court practitioners don't understand why people would choose sometimes to go to jail as opposed to come back to treatment after relapse has occurred. And I'm not saying this is the reason every time, but it's something to throw in the mix for why does this happen. Here's one of the reasons. So abstinence violation effect is the feeling of shame or guilt when you relapse that keeps you from returning into treatment and recovery. So we are so much into the development of relationships in our work. That is what we do, folks. I know we do criminal justice work also, and we do drug treatment work, and the two of them together. But so much of the work in drug court is about building relationships with our participants, engaging them in the treatment process, keeping them in the treatment process for as long as we can, until graduation, hopefully, right? And so the building of relationships is key to longer efficacy of our programs, the building of relationships. But what happens is also when relapse occurs, if our participants think that that they will disappoint us, that they will have an impact on us that might be negative, that they may also be embarrassed or feel shame or feel guilt and therefore not return to a practice. This kind of comes back to that first question we had. You know, how does it feel when you see a participant relapse? And if we're showing that to our client, that we're angry at them, that we're frustrated, that we're disappointed in them, they probably have that sense already because they probably have that same sense in themselves, right? But we need to be aware of that. How we react to relapse then factors right into this concept of the abstinence violation effect. Folks may choose to go to jail as opposed to come back and see us whom they have disappointed or feel that they have, or are embarrassed to see, or feel tremendous guilt over seeing, and then explaining this, right? So keep that in your bag of tricks. So what are the numbers on relapse and treatment? This is, strap yourselves in, put your seatbelts on, because these numbers are interesting. Never trust anybody who says the words interesting after statistics have been mentioned. Study of 1,652 treatment interventions from SAMHSA. At 1 month, 70% relapse. 6 months, 87% relapse. So at this point, actually, relapse has been studied significantly for all the treatment modalities that are out there, for all of the treatment interventions that are out there. Right? And these numbers are very similar for just about all of them. Study of compliance with any treatment regimen from NIDA, National Institute of Drug Abuse. Right? 3 months, 75% relapse. Here's a NIDA study. And actually, before I put this up there, let's see if we can get some answers. You guys, open your text box again. Here's my question for you. If there were 100 people who go to drug treatment, 100 individuals go to drug treatment, how many of them 5 years from now, according to the relapse statistics, how many 5 years from now would not have relapsed at all? Just text in a number for me and tell me. I've got 40% would not have relapsed, 70% would not have relapsed, 20%, 12%, 10%, 20%. Ah, there's a 5%. There's someone who knows their numbers. Let's take a look then. Yeah, this can upset you a little bit, but I think part of it is coming to terms with the way that psychosocial interventions work and the way that dependency, how addiction as a disease of the brain works through human beings, right? That it is a chronic illness that takes place over time and for which, although relapse is not guaranteed, there is a high chance of relapse occurring at least once during recovery. And recovery is measured in stabilization periods with life occurrences which make stabilization less stable. So for any drug treatment modality, 94% relapse by 5 years. So just sit with that for a moment. Someone wrote in a question also, so I want to address it too because it's really good. They say, if we don't let clients know how disappointing relapse is, do we lose the goal of preventing relapse? Showing disappointment is not necessarily a positive thing. It depends on the context of how it's shown. We want to have expectations for people, but we also want to have realistic expectations. And this is shown by the way we treat people when relapse occurs. We need to look at not just relapse, but what's happened before relapse. Usually what I see happen is people get sanctioned for relapse, but we forget the amount of time that they've been sober before. And that is something that needs to be kept in mind, that there's a way not just to sanction, but also to give positive feedback to people when relapse occurs, to see it as a success in that way. We're going to get into sanctions and incentives a little bit, so let's not go too far on that right now. But there's another question that came in, so I have to get there because it's in all caps, which means it's like a shout. How many relapses should occur before your state is enough is enough? It's a good question. Depends on the participant, on how chemical dependency has been working through their system, depending upon their the biological factors, the genetic factors, depending upon the drug that they were using, depending upon their environment, depending upon treatment that's been given to them and where they're at within their treatment, the stages of treatment and recovery. It depends. So it's not an easy answer to give. I'm not saying this is not a frustrating subject. What I'm saying is the more we can take relapse in the context of where an individual is at in treatment and in the context of a brain disease and how challenging relapse can be for our drug court participants, and for that matter, anyone who has the disease of chemical dependency, the more likely we ought to help them stay in treatment afterwards. And that's really what we want. We want people to stay in treatment till graduation. It would be great if everyone went through treatment without relapse. That's not the way it works. It's not very realistic. So how we deal with relapse, expecting relapse, and having that as our framework will be a lot more useful for us, right? So let's come back to our numbers here. Now I did a study on crack cocaine. I like this one because it's drug specific. 3 months, 90% relapse. So this really speaks to the idea that some substances have a higher addictive quality, right, all by themselves, as we saw in our first webinar together, that we need to kind of keep that in mind. Some drugs are simply more challenging just because of the nature of the drug itself to stay off of over time. But especially, you'll notice, the big numbers are the first month, 3 months, 6 months. So the drop-off after 6 months actually is pretty big, right? 87% by 6 months. Actually, numbers at about 90% by 6 months. Even if it's 75% or 80% at 6 months, that means there's only a small percentage of folks that will relapse after that. So the real target for us in drug court is these first 6 months. You could even say the first month during acute withdrawal, the first 3 to 6 months, which is all post-acute withdrawal, signs and symptomology, right, for a brain disease. So let's look at that then a little closer. Let's define lapse or slip. Keep in mind and work with the concept that every relapse is not the same, and so they should not be treated the same, right? Sometimes people have a lapse, sometimes they have full-blown relapse and never come back to treatment again. Sometimes they end up in jail, sometimes they leave jail, go back and start using again. Depends on these factors, biopsychosocial factors we've been talking about, right? And the kind of support they've been able to get. But recognize that sometimes you eat one Entenmann's chocolate chip cookie and sometimes you eat the whole box. There's a difference. You could even frame relapse in terms of short term, maybe 1 day up to 1 week, medium term, 1 week to a month, or long term, 1 month plus. But think in terms of how long relapse occurred, how often, and of course, what is the context of relapse. So looking at the developmental model of recovery, let's just remind ourselves, transition, stabilization, early recovery, middle recovery, late recovery, and maintenance. We're mostly working where relapse is key, right, where relapse is most likely by far to occur, right, 75 out of 100 people within the first 6 months, actually more than that, 85 to 90 out of 100 people. If you're going to relapse, first 6 months is when it's going to happen. We're looking at this period during up to and including early recovery, but mostly around stabilization. You remember what I said last week too, that skills, new coping skills, to put them in place and have them applicable for individuals can take 6 weeks to 6 months to get in place. So these numbers line up for a reason, right? And that's why it's called the stabilization process. In order to help people build new pathways in their brain to different, more healthy coping skills, right, and ways to reach the reward center and the prefrontal cortex that are not maladaptive, right, or drug using, is going to take time, 6 weeks to 6 months, which was also probably why that first month relapse is even higher. Right? So, sticking points in recovery. Marlo Wingorski again. 2 reasons, they say. Lack of skill. So again, the focus, 6 weeks to 6 months to establish new skills, right? First 6 months of treatment. That's a lot of what we're going to be doing. And then lack of self-confidence, otherwise known as self-efficacy, lack of the ability to believe in themselves, right, and their ability to get things accomplished, and their ability to see themselves differently than they are right now. So sticking points in the recovery. Let's factor that into the process. So pathways for understanding addictive behavior we've talked about already. The concept of this area right here, the prefrontal cortex, right? This is the area that we're most concerned about. It's where the damage for most drugs are going to occur, and it's the impact on the prefrontal cortex that we have to take into consideration when any behavior that would be detrimental to treatment occurs, and in particular, relapse. Keeping in mind also that for dopamine transporters, dopamine is the main neurotransmitter that works through this reward pathway, and that substances of abuse and dependency mess with, right? Here's the normal number of transporters. 1 month later, you can see treatment can start to bring them back, And then over here you can see again just a reminder how even though, for example right here, even though this red area, the high level of transporters is in place, it's not as thick and they're not in the same places as they were here, right, before. So that means that new pathways have occurred to the front, which means that people will have feelings in slightly different ways. It may feel different, right? It may not feel the same or as good in some ways as it did before, right? And the thought process may not be as efficient, okay? So addictive preoccupation, the idea of obsessive thought patterns, compulsive behaviors, physical cravings, right? These are the mainstay of what's the issues that we're working with our clients, especially in acute withdrawal, the first week to month, and then over time, depending upon things like the drug that they had used, their genetic vulnerability, as we said before, the environment that they're in, especially, right? What, as we would say, what activates their high-risk situations, including people, places, and things. We're going to come back to these three things right here because these are key for talking about relapse. Acute withdrawal versus post-acute withdrawal. So I want to put relapse in the context of the other symptomology that's occurring during these two time periods. So acute is the first 1 to 2 weeks, almost the first month. It's when you're going to mostly you go through detox to get the drug out of the system. Addictive preoccupation is in place. It's very hard to think of anything else other than where can I get the drug? What do I do with my time to get the drug? How am I going to spend my time getting the drug? Because that's when someone's chemically dependent, that's what has happened. You've had your reward pathway hijacked to the prefrontal cortex, and this is what you think about. There's not a lot of choice in it. And of course, craving occurs because we see people, places, and things which remind us of substance use and cause an automatic response in the body. And as I said, mostly physical symptoms. And it tends to be drug specific, especially the detox. So post-acute withdrawal, then 6 months to 2 years it can take, or longer, depending upon an individual's history, their vulnerability, and their environment. There are some physical symptoms, but predominantly emotional and psychological symptoms. There is addictive preoccupation, and there is craving. So let's take a look at this idea of what craving is and see how it influences the work that we do around relapse. So you can see right here, we're going to talk about something called the hippocampus. I promise you I won't get too detailed, but I do want us to have an idea of what it is and how it's influenced by substance use. Cravings are strong memories that are linked to the effect of drugs on the brain's neurochemistry. Right? So what does the hippocampus do? Well, it sorts and filters sensory data, stores it as short and long-term memory. So cravings are based on memories. They're strong memories that are linked to the effects of drugs. And they are triggered by people, places, and things. Right? Hippocampus gets us right to the VTA, which is right here, very close to the amygdala and the reward pathway, which goes forward and up into the prefrontal cortex. Bingo. That's our spot. So the hippocampus is going to be crucial in its ability to influence this process. And of course, this is the dopamine connection that we've just talked about. And triggers are what bring about these memories, and then the physical and psychological response based on that memory. So let's talk a little Pavlov. And this is a slide I took from Richard Rawson from a 2007 presentation he did. I just love his stuff, right? And I think you'll get a kick out of this also. So what did Pavlov do? Well, Pavlov would feed dogs, and he'd ring a bell at the same time. So he'd ring a bell, he'd have the dog dish, he'd put the food in there, all right, now come on, that was funny. At least I thought it was. All right, I just love the way that animation works. So the dog comes over and eats. So the dog would see and smell the food, which would then stimulate, or as we'd say, trigger their lower brain, what's called the autonomic nervous system, just one of those side comments. And what it does is it causes the dogs to produce saliva and to secrete gastric fluids in their stomach in anticipation of digestion. The bell rings, I'm ready for food. Saliva, gastric juices, bring it on, I'm ready for it. an automatic physical response, right, when the bell rings. So in a relatively short period of time, Pavlov and his buddies, they'd ring the bell without the presence of food, and this is what's so fascinating. Is dogs would still produce saliva and gastric fluid just as if the food was present. So dogs connect the sound of the bell, which is what we call the trigger, with the anticipation of eating, and they respond basically involuntarily, physically to the power of the trigger or the stimulus of this bell. So once a dog's been conditioned this way, it doesn't really matter how smart the dog is, how well trained the dog is. It doesn't matter, right? The dog's going to continue to produce fluids at the sound of the bell. The dog has no choice. So this is fascinating for implications for us, because the human brain responds in basically the same way, right? It responds the same way to is conditioned to drugs and alcohol triggers, right, or drug triggers that produce cravings also. So drugs and alcohol produce changes in the brain which result in feelings of pleasure. So when a trigger causes a person to experience cravings, the brain responds as if the actual chemicals are taken into the system. In other words, the brain is drooling in reaction to these triggers. So this reaction occurs, like I said, whether or not the person intends to use. And the only way that Pavlov's dog could avoid drooling was by avoiding the bell. So what is a lot of the work that we end up doing? We try to help our folks avoid the bell, avoid the triggers, and learn new ways to live their lives, either avoiding the triggers or coping with those triggers in some other way, because this is an involuntary response. And one other way to look at obsessive thinking, the idea of addictive preoccupation, is this whole concept of how in the beginning, remember we said reasons why people use drugs, and there are all these different reasons why people start to use. But over time, the reason they continue to use is because this is conditioned into the reward pathway. Right? This is what's conditioned into the reward pathway. So then what's the definition of a trigger? Well, a trigger is a stimulus that has been repeatedly associated with the preparation for, anticipation of, or the use of drugs and or alcohol. And these stimuli include people, things, places. So who do you buy from? Who do you use with? Who do you talk about your use with? Who do you tell war stories to? Who might you have interpersonal conflict with around? Who are you receiving social pressure from? It might be even someone who looks like you when you used before at a certain age. Oh, that person's just like me when I was there. These can all be triggers from people. Places, where are your temptations? Is it a bar, friend's apartment? Is it a shooting gallery, street corner? Is it the basement of your parents' home? Is it your room? Where are the places that you associate with substance use? Things include the drug itself, any paraphernalia like a needle, a pill container, razor, wrapping paper. Could be a jacket you used to use that has the smells that you associate with the use of the drug. Times of the day. When did you used to use? If you were a 5-bag a day heroin user, you got to have your bag first thing in the morning, right? Your wake-up bag. So that might be the most challenging time when acute withdrawal is actually starting to take place because you slept, say, 8 hours for some reason that last night. So times of day that you associate with drug use. Emotional states, and this is one of those strange things. Negative states of mind, positive states of mind. It can be a high or low feeling. What did you use to medicate? If you're medicating feelings, sometimes very good feelings of joy and happiness can be just as difficult to deal with as negative feelings can be, or uncomfortable. Events that you associate with substance use can also be events that occur which produce strong emotional responses which you associate with having to use substances. For example, life events, weddings, deaths, births, graduations. Transitional events are always something that could be a trigger. And of course, sensory stimuli, whether it's visual, auditory, tactile, or olfactory. Believe it or not, the sense of smell is especially strong as a trigger. Someone who used to work in a Budweiser brewery gets downwind. They're in recovery for alcohol use, and they get downwind of the brewery. Smell of hops and barley, right? The smell of a bar itself, the smell of a moldy couch where you and your buddies would shoot up. Smell of a parent's house who happens to have a lot of dogs, and the smell of dog then is associated. For someone who's a heroin user, it could be the sulfur smell of a match being lit, something as innocuous as that. And of course, helping people to recognize what triggers then are for them, because they could be different for each person, right? And would then be a very useful piece of relapse prevention. Just to give you a sense of what relapse prevention can look like, here's an example of 6 trigger extinction tools that are part of the evidence-based practices in the NDRI program under relapse prevention. And deep relaxation, if it stops the thought process forward, or if it stops the emotional response from building up to relapse, that's going to be useful for us. So we can see then how deep relaxation might be useful. Delay plus behavioral alternatives. For example, teaching someone to count to 10 first, to go for a walk or exercise, to induce the body's own natural opiates to work their way through the body, to feel good in a different way, right? To forge a new pathway to the prefrontal cortex, right, which is different than the old drug-using one. To call a sponsor, delay behavioral plus behavioral alternatives, helps us to develop new pathways to the reward center in the front. Negative positive consequences. What is the benefits of taking the substance? What are the deficits of taking the substance? What am I going to get out of this? What am I going to lose from this? So a balance sheet. So what is negative and positive consequences? Helping someone to exercise their prefrontal cortex, right? Their ability to problem solve, giving them opportunities to forge new pathways to the prefrontal cortex and to help modulate its capability of functioning more fully, right? This makes sense. These would be specific, right, to a brain disease. Negative positive imagery, the ability to see yourself in a positive way as opposed to just a negative way. To develop that and to create an image in your head. Remember, creating an image in your head of the way you would like to be or would like to look. This kind of a visualization, these can be very powerful because it uses neurons in our brain to access a pathway to that image. That's going to be helpful for us. Cognitive interventions or mastery imagery. Picturing yourself, okay, we did that one already. Cognitive interventions. Bring up the trigger in a therapy session with a counselor or in a group. Build the craving and then use an extinguishing technique to get rid of the craving. And then you do this in a setting that is safe and where you have help. And so you build up the passageway by repeating this behavior over and over and over. Repeating a positive coping skill that gets you the reward that you need to help use it as an alternative coping skill to the drug use. This is how we create new pathways in the brain. And again, why it's so important to use those first 6 months, right, to develop these and others. So let's look at then relapse in the context of post-acute withdrawal, as we've talked about. While the brain is healing, what are the other symptoms that are occurring? Remember, emotional, psychological symptoms such as mood swings, overreaction, numbness, irritability, our practitioners, tiredness, different amounts of energy, maybe not so enthusiastic about being in drug court or treatment, don't have the ability to concentrate very well, not able to think very clearly, not able to do problem solving, get stuck sitting there thinking, trying to think, may have disturbed sleep, may have memory problems, may have rigid thinking, black and white thinking, or repetitive thinking. We can't seem to help them step outside of that. So given this, and of course in addition to relapse, what are some of the symptoms, what do these symptoms translate into, or what behaviors do you see as a drug court practitioner that these translate into? And text in your response. Let me see a couple of those before we move on. So what are those acute withdrawal symptoms? What do we see as drug court practitioners? How do they translate? Someone wrote in, wouldn't worker reaction be part of the negative positive consequences? Yes, it would. Yes, it would. We might see missed appointments. Yep, they don't show up, right? They go, I forgot. Even though you're like, you know, we talked about this 4 times. We went over it verbally 4 times. The problem is we didn't write it down in an appointment book for them, or we didn't help them put it into their phone appointment schedule, or we didn't give them a reminder. So we have to remember, depending upon what state of addiction they're in and how that's played itself out. The challenge, like the guy trying to move that big zero off and forward, right? The challenges are the difficult parts. Someone might say bad hygiene, inability to keep themselves clean. Yeah, what do you mean I smell bad? I don't understand. What are you talking about? Right? You mean I can't wear this to go on that job interview? I don't understand, right? Restlessness, someone tapping their foot in group, staring off to out the window. They might zone out in group and totally take themselves out. Right. So these are the kinds of things that we'll see. So what are this translates into problem behaviors or attitudes, and we may define these things as the participant may be defiant, right, or they're uncooperative. They may relapse. We may think, wow, they're in denial. They're still in pre-contemplation, or they're in contemplation. They're still transitioning. They're not really in stabilization yet. They still haven't figured out that this is something that's important to take care of. They may withdraw, as you've just said. They may be suspicious. They may have low self-esteem or confidence. They may be late for appointments and no-shows, just as you've said. There may be problems at their job or at school. And, of course, we'll see more or less of these depending upon the level of addiction, how long they've been using, all these factors we've been talking about, right? How long they've been using, what the drug that they were using, genetic vulnerability, and, of course, the environment that they're in, the level of intensity of treatment. So that's what it translates into. So then what are our drug court's expectations then around these? And this is from Carolyn Harden over at NDCI, whom I know a lot of you know. This is from her presentation on sanctions and incentive. She's like, well, this is what we expect. We expect folks to abstain from drug use. I mean, this is expectation. It's a real one, and it's one that we have to put out there as part of the work that we do. We want them to show up to court. We want them to go to treatment. We want them to take random urine tests, see probation and or case management, to pay for some of these things, right? Expectations. We want them to get a job and or go to school, maybe get a GED. We want their attitude to be good. So these are expectations. So the key, though, is to see how these expectations may be able to be met by the individual or may not be able to be met by the individual depending upon what stage of recovery they are at and depending upon the type of addiction that they have. Those three factors that I'm saying over and over and over again, right? Biopsychosocial factors which are influencing. So then how do sanctions and incentives and treatment responses kind of factor into this? Well, the purpose of sanctions, incentives, and changing your treatment response is to help keep participants engaged in treatment. The longer they're in treatment, the better they do. Because this is a chronic disease of the brain, we know that longer treatment is more likely to help establish new pathways to the reward center, to the prefrontal cortex, and help folks function better, right? And if they function better, they'll be less likely to be recidivists for either criminal behavior or their drug of choice or drug use. And we know this because graduation is a key marker for success. And graduation is not usually after 1 month or 2 months. It's usually after 8 months, 10 months, 12 months, 2 years, sometimes 3 years, right? Some of our folks are in a long-term program. That's okay. They may very well need it. So purpose. Goal is to help change behavior. It's not to punish. It's to change behavior. Right? We want them to change the behavior. We want them to find new pathways in their brain. We want the brain to be repaired. We want them to find new pathways to the prefrontal cortex so that they can function and feel in ways that will be helpful for them to exist in society in lawful ways. We also want the sanctions to be a minimal amount of punishment, just enough to achieve the necessary program compliance. And we want the incentives to show, to be in place because that positive reinforcement is more powerful for changing behavior. And this is just, I'm going to read you a quote from Judge William Meyer, the Senior Judicial Fellow at the National Drug Court Institute, on sanctions incentives, a paper he wrote on it. He says, punishment often engenders behavioral suppression, fear, anger, as well as escape and avoidance responses. The effects of punishment are transitory, with the punished behavior returning when the punishment contingency is removed. So punishment teaches what not to do, while reinforcement contingencies, incentives, teach what to do. And if we want to provide new pathways to a reward, right, we got to have reward. Punishment is most effective when coupled with other behavior modification techniques such as positive reinforcement. So for example, he says, if a drug group participant has a positive drug test, the participant should be sanctioned for the positive test, but praised for the fact that he or she is attending treatment regularly, which speaks exactly to what I was talking about earlier. And of course, behavior change equals brain pathway changes and repair. And that's really what we're looking at here. Treatment, changes in treatment, which are appropriate to the stage of recovery and to where the individual is at, is then based on ongoing assessment and reassessment over time with your client. It's also one of the main reasons why we have stage-based treatment, because we know that individuals' needs change over time as damage gets repaired. So summary then, some of the things that we've talked about in these last 3 weeks together, right? Let's see if we can sum up all this information and end up with a little bit on relapse. Addiction is brain disease influenced by the drug used, genetic factors or genetic vulnerability, and the environment, right? So chemical dependency using the disease model. Damage to the brain can be repaired over time. So this is important. Treatment helps. Behavioral treatment, psychosocial treatment, in addition to biological treatment, right, helps repair pathways to the brain, right? And what we do is we use a biopsychosocial scientific approach to treatment through the evidence-based practices that we have. A damaged prefrontal cortex impacts on the ability of our participants to focus, to make decisions, to problem solve, and to feel. This influences on their capability to work with us, to adhere, to be compliant, and to do the work that we have expectations of them around doing, including being abstinent, right? Chronic illness requires ongoing, changing treatment at different levels of intensity with specific components. So we have treatment modalities with levels of intensity and treatment components that we hope to make specific to the needs of an individual, or as specific as we can, depending upon where they are in the recovery continuum. That there are stages of recovery and that treatment should correspond to that stage. We deal with detox in the first couple of weeks. We deal with skills work very quickly and as fast as we can, so in the first 6 months there's a base of stabilization to build from. And of course, last but not least, understanding that addiction and its impact on the brain allows us to view relapse in a realistic context and determine appropriate treatment response. All right, so sanctions and incentives need to help clients stay engaged in treatment and succeed through graduation. So in other words, relapse should not automatically equal for every person going back to jail. It should be what the individual person needs based on the mitigating factors of addiction and the illness of chemical dependency as a brain disease. So with that, we've got a couple minutes. If there are some questions, let's take them now before we sign out to end our three-week series. Send them in right now, and I'll read them out loud, and we'll see what kind of an answer we can give for you today. Relapse is a hard area to work with. It brings up, as you can see from the very first slide, I'm just going to talk, by the way, until someone writes in a question, so I'll go right ahead. From the very first slide, how we respond to relapse, the strong feelings that we as practitioners have about relapse. I'm not telling you not to have the feelings. I'm saying be mindful of how you react and how our clients see us react to them, so that they know that we understand chemical dependency and that we're behind them in this long-term process, right? Someone wrote in a question, how do you show law enforcement on the team that jail is not the best approach? Well, one of the ways to do that is to help them to go through courses like this, to give them background on the disease model and to talk about how dependency, how addiction as a brain disease impacts and symptomology for the folks that we're working with, what it helps them to be capable of and what it helps them to be incapable of. And I think that understanding can go a long way to start that process, right, to start that process with them. So understanding what craving is, understanding why relapse occurs, this is going to be crucial, right? So someone also wrote in, how do we deal with defensiveness of the person in recovery? So that's defensiveness is a word I'd need even to be defined a little further. But defensiveness would make a lot of sense for our participants because of the way they feel, tired, inability to comply, struggling in treatment. People will tell you all the time, right, man, treatment is harder than going to jail. Well, it probably is in many ways. We are asking folks to do significant work in treatment, and maybe that's part of the process of reminding ourselves the work they're doing and their capabilities, and then reframing where we're at. Usually when folks are defensive, it means we've probably pushed them past their capabilities at that moment. It doesn't mean they won't be capable of doing what we want them to do later. It just means right then and there that may be too hard for them. So sometimes it means we need to back off and figure out what's going on here. Why is defensiveness here in place, and how do we work forward with this person right there? All right. And with that, it's we've got a full hour in. I hope you've enjoyed these 3 webinars. I've had a lot of fun working them through with you guys. We are going to sign off, and when we do sign off, I want everyone to remember to please fill out the surveys, which will come up right after the webinar ends, which is an evaluation which tells American University, of course, myself and us here at NDRI how we did and what you think can be improved and what you think we're doing well. And those are really helpful. Thank you, Clyde Frederick, our Senior Administrative Technologist, our whiz behind the scenes, for keeping everything running smoothly. And thank you all for participating. I hope that this was of use to you. I look forward to seeing you guys all sometime in the future on either webinars or face-to-face training somewhere in the country.